Good morning, students. Today's my topic is differential diagnosis on broncho-obstructive syndrome. And today we're talking about COPD and bronchial asthma. What means broncho-obstructive syndrome? Broncho-obstructive syndrome is a clinical symptom complex caused by impaired airflow through the bronchi due to narrowing or occlusion of the airways with a subsequent increase in the resistance of the airways to the inhaled airflow. Clinically, broncho-obstructive syndrome is manifested by shortness of breath, suffocation, paroxysmal cough, wheezing, noisy breathing, and the particularly or axonal muscle of the act of breathing. Leads mechanism of broncho-obstructive syndrome. Its three main mechanisms. First, it's reversible. It's malfunctional. And the reason is spasm of bronchial smooth muscles. It's specific for bronchial asthma. Second, this inflammatory demonstration of the mucous membrane, submucosal of the bronchi. The reasons can be bronchial asthma, COPD, or pneumonia. And the third, hyperangiochromation. It's specific for bronchial asthma and COPD. Second big reason is irreversible. It's bronchial remodeling. It's specific for fibrosis. Second, irreversible reason is expectorate collapse of small bronchi. The third irreversible reason is kinesia of the membranous part of the trachea and bronchi. Specific for prolapse during the inhalation into the lumen with a subsegmental decrease in diameter of the bronchi by more than 1 to 2. Additional mechanism of the broncho-obstructive syndrome is violation of mucociliary clearance of the bronchi, ganglion blockade of the bronchi, and compression of the bronchi from the outside. Clinical picture. You should ask about history, complaints of the patient, physical examination data. It's all specific important for diagnosing broncho-obstructive syndrome. Laboratory instrumental research methods include general blood analysis, sputum analysis, X-ray of the chest, ECG, spirography with physiological test. And you should use beta agonist short action such as salbutamol or phenaterol. It should be increased of FeIV1 Tifno index. Next, this is the pulse oximetry. Sputum examination of acid-fast bacteria specific for tuberculosis. It's for patients who have a cough more than 2 weeks. Bronchoscopy is not main but additional method of diagnostic. And CT of the lungs, of course, by indications. Now talking about COPD, chronic obstructive pulmonary disease. This is a heterogeneous lung condition caused by chronic respiratory symptoms such as dyspnea, cough, sputum production, and exacerbations due to abnormalities of the airways, specific bronchitis or bronchiolitis, and or alveolar specific for emphysema that cause persistent, often progressive airflow obstruction. Talking about epidemiology of this disease, currently COPD is one of the most common human disease, which is due to ongoing environmental pollution, increasing tobacco smoking, and reducing respiratory infection disease. In the world, according to World Health, this lot of people, and you see how to 12 million people worldwide suffer from COPD. 3.3 million patients died from COPD. And this is very high numbers of patients. The prevalence of COPD was 2,338 people per 1,000. Mortality was 42.5%. According to the Minister of the Health in Belarus, I haven't the results, I haven't according to Russia, and this 2.4 million people suffering from COPD, and this about 11 million people, including undiagnosed cases. So that's basically we don't know about the disease. COPD is the third leading cause of the death in the world, and 2.8 million people die from COPD each year. And this is the reason of death, 4.8% each year. In Europe, mortality from COPD varies significantly, and from 1.2 per 1,000 population in Greece, Sweden, Iceland, and Norway. And the main cause of death in patients with COPD is progression of the underlying diseases. About 58% of COPD patients die from respiratory causes, either during exacerbation of COPD or from lung tumors, as lung cancer, or from other respiratory problems, for pneumonia, for example. What are the risk factors of the COPD? First of the main is the smoking. It's the main exogenous risk factor for the development of COPD. Cigarette smokers have a higher prevalence of respiratory symptoms and pulmonary function impairment. A higher annual rate of decline in formed expiratory volume in the first second FIV1, and a higher mortality rate from COPD than non-smokers. However, less than 50% of heavy smokers develop COPD. Passive exposure of cigarette smoker, other type of tobacco smoking, and marijuana is also a risk factor for development of COPD. Smoking during pregnancy poses a risk to the fetus by threatening lung growth and development in utero, and possibly primarily the immune system for abnormal COPD response in the future. Second, this risk factor other than smoking, especially in low and middle income countries, may be responsible for up to 50% of COPD causes, such as food, animal manure, crop residue, and coal. Biomass, usually burned in poorly functioning stoves, can lead to very high levels of air pollution in homes, which is associated with increased risk of development COPD. So, that COPD in non-smokers compared to those who smoke in more common in younger women. The next risk factor. These occupational risk factors include the organic and inorganic dust, chemical and smoke, and rapid station and endogenous risk factors for the development of COPD. According to the third National Health and National Examination Survey, the accidence of occupational exposure rated COPD was about 20%, and 31% among never smokers. Next risk factor, air pollution, which typically consists of particulate matter, ozone, nitrogen, or sulfur oxygens, heavy metals, and greenhouse gases, is the leading cause of COPD worldwide. Endogenous factors in the development of COPD are genetics, gender, and individual characteristic of lung development. Next, poverty and lower socioeconomic status are associated with airway obstruction and an increased risk of development COPD. Asthma and atopy in infancy are significant risk for the development of COPD in adulthood. Severe respiratory tract infections in childhood are associated with decreased lung function and increased incidence of respiratory tract symptoms in adulthood. Chronic obstructive bronchial infection, especially Pseudomonas aeruginosa, is associated with an accelerated decline in FIV1. Tuberculosis and HIV infections are risk factors for the development of COPD. This is prognosed etiologies for COPD. And this is the classification genetically determined COPD. It can be described as alpha-1 antitrypsin deficiency as genetic variants with small effects acting in combination. It can be COPD due to abnormal lung development and early life events, including premature birth and low birth weight, among others. and others environment COPD, cigarette smoker, biomass and pollution exposed COPD, COPD due to infections, COPD and asthma, and COPD of unknown causes. In terminology of COPD, we see some individuals may have structural lung lesions, emphysema, and or physiological abnormalities such as hypertension, decrease in lung diffusing capacity, or rapid decline of FiV1 without airflow obstruction. Its normal ratio FiV1 to FiVC more than or equal 0.8 after bronchodilation using test. Those patients are diagnosed with pre-COPD if the spirometry is normal or previous the bed ratio spirometry if it is abnormal. Patient with pre-COPD algorithm may develop in the future a COPD over time. And now I will use the report of COPD, this global initiative for chronic obstructive lung disease. And from these guidelines, clinical indications for concerning a diagnosis of COPD. And more specific disease that's progressive over time, worse with exercise and persistent. This means specific clinical signs for COPD. Recurrent wheezing, chronic cough, recurrent lower respiratory tract infections, and history of risk factors. It's the same: tobacco smoking, smoking from home cooking, occupational dust, and host factors. Differential diagnosis of COPD. It's very important. If we don't know the reason, we can't give rational treatment. COPD, bronchial asthma, congestive heart failure, bronchiectasis, tuberculosis, obstructive bronchiolitis, and diffuse bronchiolitis. This is the main diagnosis that we should have a different diagnosis between them, all these. And here in the scheme you can see the all specific main symptoms for all this disease. And for COPD, these symptoms slowly progressive, history of tobacco smoking, or other risk factors. Gold grades and severity of airflow obstruction of COPD. Of course, it's based on post-bronchodilator data, FiV1 test, using birdshot beta agonist. In COPD patients, the ratio of FiV1 to FiVC less than 0.7 is specific for all of these from first to fourth stage. For GOLD 1, FiV1, this mild stage, it's equal or more than 80%. It's a normal FiV1. For GOLD 2, it's a moderate grade. FiV1 less than 50 and from 50 to 80%. For GOLD 3, severe, from 30 to 50%, and very severe FiV1 less than 30% is GOLD 4. Dyspnea Rating Scale, modified British Medical Research Council. This is a scale of dyspnea. It has 4 grades. First, this patient have a short of breath when hurrying of the level of walking up a slight hill. Grade 4, its patient have this breathlessness, walking on their own place on the level. Grade 3, patient should stop when he have a physical exertion about 100 meters or after a few minutes of the level. And grade 4, patient had breathlessness at rest. CIT assessment is a questionnaire, 8 questions, and then you should check this total score. Patient can answer from 0 to 5. More score, but for COPD. And here you can see that questions you should ask your patient. ABC2 for initial assessment of COPD. The previous ABCD as you know, tool for initial assessment diagnosis of COPD selecting patient group and initiate of drug therapy COPD has been replaced by the ABC assessment tool. The criteria for assessing patients to group E and B remained unchanged, but group C and B were combined into a single group E. So now we have only three ABC group. Group A include patients with modified medical research consent (MS) score from 0 to 1 and COPD test score less than 10 and no or one exacerbations. Moderate exacerbations did not lead to hospitalization in the previous year. Group B include patients with MRS score more than or equal to, CIT score more equal than 10, and you had no or one moderate exacerbation that did not lead to hospitalization in the previous year. Group E include patients with more or equal to moderate exacerbations or an one equal exacerbation leading to hospitalization in past year, regardless of MRS or CIT scores. Why it's so necessary for us to know which group constipation A, B, or E? Of course, it's important for treatment of our patient, and here you can see that this is called ABC assessment tool. And how can we decide if the patient in group A or B or E? This all depends on this and symptoms and MRS scale and CIT test and exacerbation history. Therapy. It is recommended, as before, that drug therapy for patient in group A begin with bronchodilators. For patient in group B, combination therapy with two long-action bronchodilators, LABA, combination with LAMA, is recommended as more effective than monotherapy. It is recommended to initiate drug therapy in group E patient with double combination therapy LABA and LAMA or triple combination therapy LABA, LAMA and glucocorticosteroids if blood eosinophil level more than 300. Combination therapy with LABA and glucocorticosteroid is no longer recommended for patients in group B and E. If there are indications for inhalated glucocorticosteroids, triple combination therapy with LABA, LABA, and AJS is recommended as it is more effective than double combination therapy with simply LABA and inhalated glucocorticosteroids. If a patient has COPD combined with asthma, then asthma needs to be treated. Flow-up therapy is aimed at reducing shortness of breath and the frequency of exacerbations. Patients with persistent shortness of breath or exercise limitation who are recovering bronchodilated monotherapy are advised to switch to a combination LABA and LAMA therapy. If the therapy does not help, your doctor should consider changing your inhalator on medical and underlying and treating other causes of shortness of breath. For patients with persistent exacerbation of COPD, with or without dyspnea or bronchodilated monotherapy, it is recommended to switch to double combination LABA and LAMA, except for patients with blood eosinophils levels more or equal 300, who should consider switching to triple combination LABA, LAMA, and inhalated glucocorticosteroids. Patients with persistent exacerbation of COPD during dual combination therapy of LABA and LAMA are recommended to switch to triple combination therapy of the LABA, LABA, and glucocorticosteroids if they have a blood eosinophils level more than or equal 100. In a patient with persistent exacerbation during triple combination therapy of LABA, LABA, and inhalated corticosteroids, or patient with blood eosinophils level less than 100, the additional is of romilast, is inhibitor of phosphatase stress, especially a patient with chronic bronchitis or a predictive FeV1 less than 50%, or a macrolide, especially current non-smokers, is recommended time for patient. The use of combination therapy of a dietary supplement and together with inhalated glucocorticosteroid is possible when the patient who does not have asthma has been treated with previously, and the COPD is well controlled in terms of symptoms and exacerbations of the disease. In case and further exacerbation of COPD, it is recommended to switch the triple combination therapy of LABA-LABA and glucocorticosteroids. If symptoms persist, it is recommended to switch from LABA and glucocorticosteroid therapy to LABA and LAMA therapy. Combination therapy of LABA-LABA and AGS is effective in reducing mortality from COPD. Individual choice of inhalator for each individual patient indicate in the treatment of COPD. The inhaler is selected jointly by the physician and the patient based on the characteristic of the inhaler. The patient's preference and the ability of the patient to maintain proper inhalator technique. Non-drug therapy includes increasing patient knowledge about COPD and its therapy, smoking cessation, vaccination against influenza, pneumococcus, COVID-19, proven cough, herpes zoster, physical activity, and restoration of lung function. Here you can see commonly used maintenance medical in COPD. In this table with beta agonist short and long action, anti-allergic drugs short and long action combination drugs, short action beta agonist with anti-allergic drugs combination or and LABA, LAMA, and the methylxanthines that we can use aminophylline, teophylline combination of LABA, LABA and glucocorticosteroids, triple combination, phosphodiesterase inhibitor, flumelast, and mucolytic therapy is in pills, 3 drugs that we can use for patient treatment of COPD. This initial pharmacological treatment according to the group A, B, or E. For group A, which is a bronchodilatator, for group B, LABA and LABA combinations in therapy may be more convinced and effective than multiply inhalator, you can see according to this guidelines. And group E, this combination LABA-LAMA and with together include glucocorticosteroids is blood eosinophils more equal 300. Definition of exacerbation of COPD. Exacerbation of COPD is condition produced by shortness of breath or a cough, sputum production worsening over less or equal 14 days, which may be accompanied with tachypnea or tachycardia, and is often associated with increased local or systemic inflammation caused by respiratory tract infection, environmental pollution, or other respiratory tract lesions. Comorbidity and COPD. COPD often has comorbidities such as cardiovascular disease, lung cancer, bronchiectasis, sleep apnea, autoposis, diabetes and metabolic syndrome, acid reflux, anemia, secondary polycythemia, and mental disorders, which has a significant impact on the patient's condition and prognosis of COPD. The presence of comorbidity should not affect the treatment of COPD and should be treated according to normal stance regardless of the presence of COPD. What are the new recommendations? A new genotype has been developed that pre-diagnosed patient to COPD, hereditary alpha-1 antitrypsin deficiency. Electronic cigarette use associated with acute lung injury, eosinophil pneumonia, alveolar hemorrhage, respiratory bronchiolitis, and other forms of lung pathology, and sometimes death. According to 20-year, this is around 300 causes of lung illnesses and 68 deaths has been linked to the use of this electronic cigarette vaping product. Therapy with systemic glucocorticosteroids improves the clinical conditions of the patient with lung damage caused by the effect of cigarettes. Vitamin E acetate used in some cigarettes has been associated with lung damage. Patients with COPD are recommended to be vaccinate against whooping cough, tetanus, and diphtheria if they were not vaccinated during adolescence. Patients with COPD who smoke a large number of cigarettes has a reduced effect of inhalated corticosteroids, so it needs they have more dose of this drug compared with patients who quit smoking or smoke a small number of cigarettes. Triple combination of COPD, inhalated corticosteroid, LABA and LAMA, improves lung function and reduces mortality in patients with frequent or severe exacerbation of COPD. The side effects section describes drugs with which methylxanthines have significant interactions such as erythromycin but not azithromycin, some humoral antibiotics, ciprofloxacin but not ofloxacin, allopurinol, cimetidine but not ranitidine, serotonin intake inhibitors, fluvoxamine. In patients with COPD, not received inhalated corticosteroids, regular treatment with mucolytics such as carbamazepine and acetylcysteine may reduce exacerbation and moderately improve health status. Acetylcysteine has been shown to have significant effect on mild exacerbations independent of concomitant treatment with inhalated corticosteroids. There is no evidence that beta blockers should be used in a patient with COPD who do not have a cardiovascular indication or indication for their use. Antibiotics are recommended for patients with exacerbation of COPD of three main symptoms: increased shortness of breath, increased sputum volume and purulent sputum, or there are two main symptoms, one of which is purulent sputum or the need to mechanical ventilation, invasive or non-invasive. The recommended duration of antibacterial therapy is 5-7 days. The choice of antibiotics should be based on the nature of the local bacterial flora. The route of administration, oral or intravenous, of the antibiotics depends on the patient's ability to eat or the pharmacokinetics of the drug. Also, it is preferable for antibiotics to be given orally. Beta blocker therapy is recommended for patients with heart failure, even if they have COPD. Therapy with selective beta blockers is indicated. During and for at least 90 days after an exacerbation of COPD, there is increased risk of cardiovascular events such as death, myocardial infarction, stroke, unstable angina, and resting ischemic attack in a patient with concomitant ischemic heart disease. Now talking about bronchial asthma. Definition of asthma. According to Jaina, consider asthma to be this heterogeneous disease usually characterized by chronic airflow inflammation and history of respiratory symptoms such as wheezing, shortness of breath, chest tidiness, and cough that vary over time and intensely together with variable expiratory airflow limitation. This definition highlights that people with asthma don't just exhibit the classic phenotype or allergic asthma with eosinophil inflammation, which usually presents in childhood. They may instead present with other form of asthma, which can be non-atopic, present later in adulthood, or be associated with obesity, occupation, or another risk factors. Description of asthma. Symptoms and airflow limitation may resolve spontaneously, or it responds to medication and may sometimes be absent for weeks or months at a time. On the other hand, patients can experience episodic flare-up exacerbation of asthma that may be life-threatening and carry significant burden to patients and the community. The majority of asthma deaths occur in low and middle income countries. Asthma is usually associated with airflow hypersensibilities to direct or indirect stimuli, and with chronic airway inflammation. This, which is usually persist even when symptoms are absent or lung function is normal, but may normalize with treatment. Phenotypes of asthma. It can be allergic asthma, non-allergic asthma, adult onset, late onset asthma, asthma with persistent airflow limitation, and asthma with obesity. For allergic asthma, this most early nasal asthma phenotype, which often commences in childhood, associated with a past or family history of allergic diseases such as allergic rhinitis or food or drug allergy. And patients with asthma, this phenotype usually respond well to inhaled corticosteroid treatment. Non-allergic asthma. Some patients with asthma is not treated with allergy, and this patient with non-allergic asthma often have a short-term response to neglected corticosteroids. Adult late onset asthma. Some adults, particularly women, are present with asthma for the first time in adult life. And can be occupational asthma. Should be ruled out the patient preserving with adult onset asthma. Asthma with persistent airflow limitation. Some patients with long-standing asthma develop airflow limitation that is persistent or incompletely reversible. This is slow due to airway wall remodeling. And asthma with obesity. Some obese patients with asthma have prominent respiratory symptoms and little eosinophilic airflow inflammation. Diagnostic criteria for asthma in adults, adolescents, and children 6-11 years. History of typical variable respiratory symptoms wheezing, shortness of breath, chest tiredness, and cough. Second, confirmed variable expiratory airflow limitation. Is documented excessive variability of lung function. False is positive bronchodilator test for adults increasing FeNV1 more than 12% or 12 milliliters. Then it's excessive variability in twice daily PEF over 2 weeks. You can see the results for adults more than 10%. Next is increase in lung function after 4 weeks of treatment. For adults, increase FeNV1 by 12% and more than 200 milliliters. Positive exercise challenge test, positive bronchial challenge test, it's usually for adults. Excessive variance or in lung function between visits. And second, documented expiratory airflow limitation at the time FeNV1 is reduced during the testing bowl. Confirm that ratio FeNV1 to FeVC is also reduced compared with the lower limit of normal. It's usually more than 0.75 in adults. Different diagnosis of patient adults, adolescents, and children 6 to 11 years. You see that for children, for patients from 12 to 39, 40 and older, and for all ages, you can see the symptoms and conditions. Our topic is about adolescents. We start from 40 and older. This dyspnea, respiratory wheezing, can be stridor, dizziness, cough with sputum, producing cough, dyspnea with exertion. And you see this treatment with ACE inhibitors, dyspnea with exertion and productive cough, pimaglobin, sudden onset of dyspnea, in response to bronchodilators. These are symptoms for such age and conditions that can include this. And if patient has dyspnea, respiratory bronchitis can be central airway obstruction, for example. For all ages, chronic cough hepatitis is displayed particularly for tuberculosis. If it's a prolonged paroxysmal coughing, it can be pertussis. So you can see that this is a differential diagnosis between COPD, bronchial asthma, tuberculosis, bronchitis, cystic fibrosis. So you can see that age, symptoms, and thinking about another reason, not bronchial asthma reason. Assessing asthma severity. Severe asthma is defined as asthma that remains in control despite optimized treatment with higher dose inhaled glucocorticoids and LABA, or that required high dose uh, glucocorticoids and LABA to prevent it from becoming uncontrolled. Severe asthma must be distinguished from asthma that is difficult to treat due to inadequate or inappropriate treatment, or persistent problem with all these comorbidities such as chronic rhinosinusitis or obesity, as they need very different treatment compared with if its asthma is relatively refracting to higher dose glucocorticoids and LABA, or even oral glucocorticosteroids, for how to establish difficult to treat and severe asthma, and for more detail about assessment. Moderate asthma is currently defined as asthma that is well controlled with step 3 or 4 treatment with low or medium dose glucocorticoids and LABA and acid treatment drug. And mild asthma is currently defined as asthma that is well controlled with low acid treatment, so it's low dose glucocorticoids combination with formoterol or low dose glucocorticoids plus as needed SABA. Medication and treatment for symptoms control and risk reduction. Gianna does not recommend treatment as asthma in adults, adolescents, or children 6 years with LABA alone. Instead, they should be it's a combination of glucocorticoids contain treatment to reduce the risk of serious sedations and to control symptoms. ACRs containing treatment can be delivered either with regular daily treatment or in adults and adolescents with mild asthma as need low dose glucocorticoids with formoterol taken wherever need for symptoms relief. For children with mild asthma, inhaled glucocorticoids can be taken wherever to SABA relief is taken. Reduction in severe exacerbations in a high priority across treatment steps to reduce the risk and burden of the patient and the burden to the health system and reduce the need for oral corticosteroids, which has cumulative long-term observed effect. Terminology for asthma medications, maintenance treatment. This asthma treatment that is prescribed for use every day regularly. Controller. Medication target both dominance of asthma control. Relief. Asthma related take as need for quiet relief of asthma symptoms. Anti-inflammatory reliever. A reliever inhalator that control both a low dose of glucocorticosteroids and rapid action bronchodilator. MART, maintained and relief therapy. Treatment regime is which the patient use an inhaled glucocorticoid together with formoterol inhaled every day and also use the same medication as need for relief of asthma symptoms, reliever doses. And this is the Gina statin treatment in adults and adolescents with diagnosed asthma. First step, first and second, uses as needed only low dose inhaled glucocorticosteroids in combination with formoterol. Step 3, low dose maintains glucocorticosteroids and formoterol. Step 4, medium dose glucocorticosteroids and formoterol. As step 1, add on LAMA. And we can use, according to phenotype, biological therapy. This start here. Prefer controller entry. Drugs for anti-inflammatory liquid therapy error. Inhaled preparation contain low-dose glucocorticosteroids, a fast-action bronchodilator glucocorticosteroid formoterol, or combination of glucocorticosteroids with short-action beta-2 agonist. MART. This is low-dose glucocorticosteroid and formoterol as both maintenance and response therapy. The anti-inflammatory bronchodilator regime is recommended as the first line of therapy in all stages, stage First, second, a mixed combination of budesonide together with formoterol is recommended in the as-needed mode. Stages 3-5, mixed combination of glucocorticosteroids and formoterol in the marked mode. Azithromycin. The use of azithromycin 3 times a week significantly reduces the frequency of exacerbations in a patient taking higher dose of glucocorticosteroids and LABAs, as well as in a patient with eosinophilic or non-eosinophilic asthma. There are no published data of the effectiveness of azithromycin when added to the average dose of ACS and LAMA. Before adding LAMA to therapy, it is necessary to check the sputum for the presence of atypical mycobacteria, as well as the ACG, to include a prolonged QT interval. The risk of increased antimicrobial resistance must be considered. And biological therapy. Before initiating biological therapy, it is recommended to research blood eosinophils level, and the level in low at the first assessment is a patient with severe asthma. According to studies, about 75% of patients receiving a medium or high dose of glucocorticosteroid together with LABA and changed in eosinophils level within 12 months. Additional indication for the use of drugs. Omalizumab. This is chronic diabetic urticaria nasal polyps. Mepolizumab, eosinophilic syndrome, eosinophilic granulomatosis with polyangiitis. And benralizumab, currently no additional indications. Golimumab, chronic rhinosinusitis with nasal polyp, atopic dermatitis. Thank you for your attention. See you in our classes.